Thank you so much for giving me the opportunity to be able to share with everybody. And thank you all for being willing to spend your evening with me, just at least a short time, to talk about what you might be missing with CBCT. Just some disclosures. I am paid for this presentation. I'm also the founder and managing oral maxillofacial radiologist for Dental Radiology Diagnostics, which is a private practice that is limited to radiology. We also have a website called DRDX Doctors that does have some courses on it, some of our basic CBCT courses as well. And I'm a key opinion leader for multiple of the imaging companies, also faculty at CEREC Doctors, and I do teach a course there. I'm also assistant professor for general diagnostic radiology at Loma Linda University School of Medicine and an adjunct professor at UNC Chapel Hill School of Dentistry. So there's my caveat. So the objectives for tonight were very lofty objectives. Address the common misconceptions from radiation concerns to reading and interpreting CBCT scans, learn, practical daily applications of CBCT. And for this course today, we limited that to implants and endo because there's a wide variety of areas you can use your CBCT in. Review what additional detail CBCT scans uncover that can change your diagnosis. And a lot of this can be shown in some of our 2D versus 3D images and cases. And then learn how CBCT can prevent diagnostic errors, reduce legal risks, and strengthen the patient outcomes and practice protection, as well as break down the upfront investment versus long-term benefits from ROI to patient acceptance and legal safeguards. Whew, that is a lot to cover in an hour. So we're going to really try to get through it all. I want to make sure that this time is beneficial for you. So I'm going to do my best to finish all of that off in an hour. So definitely be patient with me. But we're first going to start with our radiation risks. That is a concern that our patients have. They're concerned about maybe in utero defects. They're concerned about cancer risk and that sort of thing. As well as, some of, our staff in our offices and stuff like that. They're very concerned about that. So let's just talk about that right off the bat. So just so we're all on the same page, all life on Earth is receiving radiation every day. So you receive about 8.5 microsieverts just being alive on the Earth every single day. So while we're all sitting here, we're actually receiving some radiation. When we're talking about the annual effective dose to the population, it's about 3.1 millisieverts per year. And so largely that comes from cosmic and terrestrial sources. One of the largest contributors is the breakdown of uranium into radon. And that can filter into our homes, and that is a source for potential lung cancer. So when we're talking about our chromium CT and we're talking about dose, it's actually highly dependent on the individual machine, the volume that's being ionized, the detector type, the image resolution. We call that our voxel size or our 3D pixel size. So if you have a very fine resolution or high resolution, you typically will have smaller voxel size, and actually that can increase the dose. Number of projections. So as the CBCT is imaging your patient, it takes multiple images. And the more projections or basis projections that you have, the more dose that you'll have. So if I put it, for example, in, say, a high definition mode, that's going to actually be more dose than a low definition mode or regular mode. Or I guess it would be standard mode. And then on average, it's less than conventional medical CT. So when we're talking about dose, one of the things that you'll notice is we use something called the effective dose. And that takes into account the tissue sensitivity to ionizing radiation. And so it can be site specific. So for example, if I were to image something, say in the posterior mandible, there's certain soft tissues that are going to be within that field of view, and there are tissue weights. And so we use something called the 2007 ICRP tissue weights, again, telling us how sensitive those tissues are to ionizing radiation. 2007 was the last time they updated those tissue weights, so they're the most recent ones. So if we're going to compare dose among machines or that sort of thing, we want to look at the effective dose, because we know it takes into account the the size, the sensitivity of the tissues to ionizing radiation and that sort of thing. So when we're looking at all the machines across the market, I can say for a large field of view, which is typically about 15 centimeters or larger, it's highly variable. It can vary between 46 to up over 1,000 microsieverts. But I can say on average, a large field of view will be 212 microsieverts. Medium field of view will be between 9 to 560. For an average medium field of view, the standard protocol will be about 177 microsieverts. A small field of view can vary between 5 to 652. Excuse me. So you can see that just because it's a small field of view doesn't necessarily mean it's less dose. It's highly variable. But on average, a small field of view will be about 84 microsieverts. So I can say on average, the smaller the field of view, the less dose. But just know, there's always going to be outliers where this small field of view is much more dose than, say, a medium field of view. So there's always outliers to these. It could be highly variable. All right, so when we're talking about, say, for example, an 8x8 field of view, this would typically be, a maxilla and a mandible. And typically that's about the size we have when people are placing implants, and that's primarily what they want to do. So we're going to look at an 8x8 CBCT for an average adult and compare it to other things that we do in dentistry. So it'll be equal to about 6 to 7 panoramic radiographs. Excuse me. It's about a third of a film-based full mouth series. So those film-based full mouth series were quite a lot of dose. So I can take 3 CBCTs for one of those film-based full mouth series. So if you ever took a film-based full mouth series, if you are that generation like I am, that was so much dose that your CBCT is about a third of that in comparison. So, and from that standpoint, I would not necessarily be very concerned about dose. We can say it's slightly more than a digital full mouth series. It's about 15 days of background radiation. So what is background radiation? Again, that's that 8.5 microsieverts of just being alive on the earth. That's our per capita background radiation. So we can say that an 8x8 scan is about equivalent of being alive on the earth for 15 days. What are the chance of in utero birth defects? They're actually 0. So let's talk about that, because I did not learn that in dental school, and I don't know if maybe you did. When we're talking about ionizing radiation, there's actually 2 different effects. There's a stochastic effect based on statistics and a deterministic effect. So let's talk about our stochastic effect. Here the risk is proportional to the dose. So I can say, example, if I were to go to Vegas and, I'm throwing the dice, the more times I throw the dice, the more opportunities I would have for a 5. So the more images that you have throughout your lifetime, the more opportunities you might have to have, for example, cancer or some sort of a genetic mutation. Now, this implies that there's no threshold. And the theory behind this is that the damage from ionizing radiation at some point is beyond what your body can repair. And again, a cancer or a genetic mutation may begin. Now, the severity of the effect may occur. The severity of the effect is independent of the dose. So if Mrs. Jones is, say, for example, diagnosed with stage 4 cancer, it doesn't necessarily mean she had more dose. It just means at some point, something caused the cancer to begin. Then we have our deterministic effect. And here the severity is proportional to the dose. And we actually do have a defined threshold. So I can say, at X amount of radiation and above, I will see this effect. At X amount of radiation and below, I will not see this effect. So we have a defined threshold. And we see this with a couple of different things, such as our in utero birth defects. There's actually a radiation cataracts that looks different than senility cataracts, and there are radiation burns. Now we have sunburn on here, not because we want to equate having an x-ray with being out in the sun, but a sunburn is a deterministic effect. It's a time-dependent deterministic effect. And so, for example, if I were to go outside into the sun for 15 minutes, I'm probably not going to get a sunburn. But if I sit out in the sun for 4 hours, I'm probably going to get a sunburn. So it's on there as an example of a deterministic effect. But that one's time dependent. So when we're looking at this, the dose threshold for birth defects is between 100 to 250 millisieverts. And in dentistry, we are down in the microsievert range, which is orders of magnitude below that. So these are some of the references from the Health Physics Society. It says most diagnostic procedures expose the embryo to less than 50 millisieverts. This level of radiation exposure will not increase reproductive risks, either birth defects or miscarriage. And according to the published information, the reported dose of radiation to result in an increased incidence of birth defects or miscarriage is above 200 millisieverts. And again, in dentistry, we're down in the microsievert range. So we're orders of magnitude below where we would ever see that happen. But even so, we are still very careful because we tend as a group to take a lot of images. And so the dose of the population as a whole does tend to be more in dentistry because we are taking so many images collectively. So a lot of the CBCT units will have a low dose protocol, which is really amazing. Pardon me. It is definitely allergy season, so I do have my drink here. I apologize. All right, so they do have a low dose protocol. So it's, for example, this is an image with a low dose protocol. This was taken for implantology. And we can see that this is a 46-year-old patient. The field of view was 11 by 10. He was just coming in for an implant check. So they wanted to know, for example, where the implant is in relationship to the mandibular canal. And we can see that. The effective dose of this was 9 microsieverts. So again, just a little bit more than a day being alive on the earth. Just for reference, if we're talking about a panoramic, that's about 14.2 microsieverts. So this is less dose than a 2D pan, and we have all of our 3D capabilities, which is pretty amazing. And we're talking, for example, about, 4 bite wings. 4 bite wings is actually approximately 5 microsieverts. So this is just a little bit more than having a set of bite wings. This is another one, low dose protocol. This is for orthodontic purposes. And so, of course, we have the pediatric population. We probably don't need the very fine details that you might want, say, if you were an endodontist. And so because of that, it is a little bit more of a noisy image, but you can see exactly where that canine is in relationship to the other teeth. This is a 17-year-old male, and this is a 5 by 5 field of view. And it's 3 microsieverts. So it is less than a dose of 4 bite wings. And again, you have all those 3D capabilities. So it's really just amazing to see where all of this technology has gone to ensure that we're using the lowest possible dose for our patients. Now, of course, we can always compare dose to a 1 in a million risk of dying. And so there's different things that we can equate that to when we're talking to our patients, because sometimes when we're talking about per capita background radiation and 8.5 microsieverts, the patients don't really understand what that means. And so we can compare it to other things that have a similar risk of dying. So one is 20 minutes, male aged 60. So I've been talking for almost 20 minutes. And so if there's anybody out there that is male age 60, while you've been listening to me, you've had a 1 in a million risk of dying. Isn't that a great thought? But or you've had the equivalent risk of a CBCT scan. 2 days in New York, maybe 6 minutes in a canoe, or if you're this little person right here, it's probably going to be a lot less than 6 minutes in a canoe. Every 10 miles bicycling, every 300 miles in a car. And what about flying? So, for example, if Mrs. Jones were to win a free trip from JFK to Sydney, Australia, she would be very, very excited about that. She wouldn't say, "Oh, I can't take the trip because it's too much dose." So it's really all in our perspective and our priorities. Of course, we have 1.4 cigarettes. So how many of your patients smoke? Maybe they smoked before they walked into your office, and then they tell you, "Oh, I can't have those x-rays. That's too much dose." Oh, what did you just give yourself out there in the parking lot? The equivalent of risk of a CBCT. So it's, being able to talk to our patients about it and help to educate them as far as the dose risks is very, very important. Now, we do have the same guiding principles as 2D. Justification, optimization, and dose limitation. We just need to be able to justify why we're taking the scan. We want to optimize it, so use the smallest field of view to achieve the task that you are interested in. And of course, dose limitations. Use the appropriate exposure setting for the patient. We don't need to over or underexpose the patient. And actually, what we see with CBCT a lot is people tend to underexpose the patient, which is actually a little bit more dangerous than, over. But in any case, dose limitation. We want to make sure that if it's a large adult patient, don't be afraid to take it at the large adult. But if it's a pediatric patient, please do use the pediatric setting. Right, of course, we have our principles. ALARA, as low as reasonably achievable. And again, as I said, that, it is actually possible with CBCT to be too low. So we really want to move more towards ALARA, as low as diagnostically acceptable. Sometimes, again, we're afraid to use the appropriate exposure setting for that patient. We'll think, "Oh, she's a small person. I'm just going to use the pediatric setting." And then when you look at the scan, there's a lot of noise in your image. And so what happens in a case like that is you would actually have to go back and re-image the patient, which would result in more dose. So just take it at the appropriate exposure setting the first time. Don't be afraid of it. But we always, of course, want to be careful. And please don't use a thyroid collar with a CBCT. This was a great case. One of our residents got talked into putting a thyroid collar on. Of course, Mrs. Jones is about a 60-year-old female. She watched Dr. Oz. She's very concerned about dose. If you use a thyroid collar and it gets in the field of view, you can see that we have a lot of these beam hardening artifacts, and it really renders this volume as not diagnostic. And so what happens now is you have to go ahead and retake the scan, which results in more dose to the patient. So for that reason, and the reason that the majority of dose to the thyroid is actually internal scatter and not external scatter, we would say do not use a thyroid collar with a CBCT. If the patient insists on a thyroid collar, then CBCT is not the imaging modality for them. All right. So 2D or 3D, when do you go into 3D? And it really is any time that 2D does not give you enough information. If you're looking at the 2D, patient's in pain, you're not sure exactly what's going on, feel free to go ahead and move into 3D. That is your justification. All right, so who is responsible for reading the CBCT? Well, just like all of the rest of our images, it's the dentist who obtains the volume. So if, for example, you take a pan or lateral ceph, you're responsible for reading everything in that in that image. And actually, if we're talking about pans and lateral cephs, you're already seeing the cranial base and some of those other areas that freak you out about cone beam CT. So we were already responsible for all of these areas. It's just actually much harder to see them in 2D. In 3D, it's so much easier to be able to see what's going on, to be able to compare one side to another. And so from that standpoint, if I was to interpret a scan versus, say, a pan or ceph, I would much rather interpret the 3D scan. It's much easier to read. What's our ethical and legal responsibilities? The entire scan volume should be examined. So many times we're taking, a full large field of view, and we're seeing a lot of things. But yet people want to just go down and look at the one area that they're concerned about with implants. And what that does is, you're essentially discounting all of the other items in that CBCT. You actually have the opportunity to catch things way before your patient has any sort of detriments or issues or anything like that. So do we see lesions at the cranial base? Yes, we do. And if they calcify, we will see them on our CBCT. And you, as the dentist, will actually catch them first. And you will, trust me, be completely the hero to your patient, because your patient's much more likely to see you than their medical doctor. And so for that reason, because we do see other things, we do say the entire scan volume should be examined. Now, is that something to be afraid of? No, it's not. We'll talk about that. So don't freak out about that. But the entire scan volume should be examined because you're getting that information and you want to be able to take care of your patient. That's the whole reason that many of us go into this profession, or wanting to help people. You can really help your patients in a very big way with your CBCTs. It really shows you more moving towards that whole patient care, because the things that happen in the oral cavity are really representative of that patient as a whole. And so when you think about it as more of a holistic treatment, the window to that patient's health is really through their oral cavity. So we want to review the entire CBCT volume. We want to be able to recognize abnormal and refer appropriately. And there's free training that's offered by many of the manufacturers. I would say, please take the free training. It's included in the price of the CBCT anyway. So definitely take advantage of it. We know that really only about 60% of dentists will take advantage of that free training. And with any type of technology, you do want to go and take training, learn the tips and the tricks and that sort of thing. So I would highly encourage you to do so. There's also oral maxillofacial radiologists like myself that are very willing to help. We are excited about this technology. It's an amazing technology. It has the opportunity to really help your patients as well as your practice. So I would highly encourage you to think about cone beam CT if you don't already own one. We're talking about a radiologic interpretation. That's the ability to see and understand what is revealed by a radiographic image or a CBCT volume. And that seems pretty self-explanatory. But we do know that learning how to visualize all of the gray values in the CBCT does take time. There is a learning curve to it. So you do want to be patient with yourself. Again, you do want to take courses and that sort of thing to help you to be able to, identify what a radiologist might be looking at, how we might think about things and go through a scan. And so a lot of the research that we did, did really show, when we're looking at 2D versus 3D, that, people early on are more willing to trust the 2D because that's what we've been used to. But once you've had a CBCT machine for, about 6 months to a year, you're going to see so many things that you're going to start trusting your CBCT machine much more than the 2D. And the 2D, again, remember, we have a lot of superimposition with that. We have superimposition of cortical borders, but with cone beam CT, we are looking between the cortical borders. So we're actually able to see what's really going on for that patient. All right, so what are our keys to a successful interpretation? First of all, diagnostic cone beam CT volume. We want to make sure that there's no motion artifacts. It's taken at the appropriate exposure setting. And course, proper viewing conditions. We do look at things in a dark room. I always joke about this, come on over to the dark side. Don't be afraid of it. But you can see a lot more gray values when you're looking at your coming CT in a dark room. Understanding of normal anatomy. And again, that's why I would say go and take a course, or, sit down with a good anatomy book and review your anatomy, but definitely take a course. A knowledge of head and neck pathology. So again, at a course, they would review that head and neck pathology with you. And then, of course, you want to have a systematic approach to evaluating that patient. So our systematic approach, we want to take our patient into account, as well as review existing radiographs. We want to use a systematic search pattern. So we want to go from a more global review to a more local review of that CBCT. And we're really looking for things like lack of symmetry. Does the right side look like the left side? And if it doesn't, maybe there's something that is going on, and we might want to refer that scan. In fact, once you refer that scan, your liability is done, and you've passed that on to the radiologist. We want to describe our findings. And so as we describe our findings, it really helps us to better identify all of the features, the biological aggressiveness of a particular entity, and of course, the independency of imaging modalities as well. So we'll talk about that in just a little bit. And then it's going to drop it into a certain category, and that is going to help us to manage the case. The proper viewing sequence. Typically, I'll look at things more globally, and I can do that with my axial and my coronal sections because I can compare the right side and the left side with my axial and coronal sections. I can determine if the image is diagnostic. Again, looking at that symmetry of form and density, looking at our cortical borders, making sure that they're smooth and intact. And then, of course, we can look at things more locally in our sagittal sections, which go from side to side. And I don't have another side to compare. I don't really have symmetry with my sagittal sections, but it's a great place to look at my periodontal ligament spaces, my lamina dura, evaluate the root form and canal structure, and assess crowns for any type of abnormalities. Okay, so our interpretation principles: recognizing our normal anatomy, independence of radiographic science to imaging modalities, principle of symmetry, terminologies and description, and our categorization. So again, having that mental picture of normal anatomy is very, very important. I know that, I talked about taking a course, looking at a book. I think we do have an anatomy CBCT course on my website as well that you can go to and look at. Just having that mental image of normal can help you determine if what you're looking at is normal versus abnormal. And of course, regardless of your imaging modality, your radiographic signs of disease are actually the same. So if it looks like a cyst in 2D, it's going to look like a cyst in 3D. You're not reinventing the wheel, so don't be afraid about that. And again, using symmetry and using our axial sections, I can compare one side to the other side. I can say this side looks very similar to that side. I know this is normal. Again, the coronal sections, I can compare one side to another side. Very, very helpful. In fact, that's what we typically will tell our residents when they start. Use symmetry. It's very, very helpful. Okay, so here's some examples of using symmetry. I may not know exactly what this pathology is, but I know that this side looks very different than that side. And yes, I have a large lingual tori, but it looks like something's kind of pushing in on the bone. I'm not sure what that is. Here's another one. When I'm comparing this side to that side, I can see, yeah, there's some obvious pathology in this region. Again, we've got some tooth displacement, obvious thinning and expansion of cortical borders when I compare it to the other side. So I may not know exactly what these are, and that's okay. But I know I want to send this on because it doesn't look right. And that really ends your liability and your concern as far as liability goes. Again, radiographic signs of abnormality should be observed and understood. So I can say, for example, well-defined corticated radiolucency, or we would call it a hypodensity because we're talking about CT. And so, that would drop it into a category of maybe a cyst versus, say, a benign tumor. So, what are the radiographic signs? These are the radiographic signs. A radiographic density, marginal characteristics, shape, location and distribution, size, internal architecture, and effects on surrounding tissues. And the two that are underlined are actually the most important because they tell us about how aggressive a particular entity is. So those are the two we really want to pay attention to. And then, of course, then it's going to drop it into a category. Is this normal versus abnormal? Maybe it's developmental versus acquired. And then if it's acquired, is it trauma or inflammation? And these are things that in dentistry we're very, very good at. Our acquired pathologies like trauma and inflammation we see day in and day out. And that's probably going to be about 95% of what we see. About 5% of the time, we might see maybe a hydrostatic appearance. That would be a cyst. We can see a benign fibroosseous entity or lesion of bone. Typically, those have a ground glass appearance, a mixed density appearance. And then occasionally, we might see a benign versus a malignant tumor. Lastly, we might see something that is systemic or metabolic. And with that, what we really need to remember is that this will be generalized. So you're going to see a generalized change in the bone, and that will be in the mandible, it'll be in the maxilla, it'll be in the cervical spine, it'll be in the cranial base. It will be widespread across that entire patient. And that's kind of our clue that we're looking at something that's probably systemic or metabolic. And then we come up with an impression as far as what we think that is. All right. Moving on to some of our applications for our 3D imaging. So we really started reviewing all of this imaging, or the imaging was really brought into dentistry to look at it for implant treatment purposes. And that's really what brought cone-beam CT into dentistry. I believe it was about 1998 was when the first papers came out by Mozo talking about cone-beam CT. Now, before that, if you wanted to look at your patient in 3D, you would have to send them for medical CT, which again was much more dose. But of course, we can see other things like developmental abnormalities, third molar and canal relationships, periapical and periodontal findings. And I know we're going to talk about this in a little bit more depth, but that's actually what really brought me into 3D imaging. I was a general dentist for about 6 years. And then, I had a couple of cases with patients, as we do, where you've done the root canal treatment, you've placed the crown, the patient still has continued pain, and the 2D doesn't really show you why. I was very, very interested in the 2D versus 3D. Of course, when I went to school, this would have been called a failed root canal treatment. When I went back to school, I learned that the terminology had changed. We're a little bit more PC because, of course, we didn't fail. The tooth just is unresponsive or non-healing. So now they call it an unresponsive tooth or a non-healing root canal treated tooth. So, so somebody told me, you know what, if you did the root canal, it failed. But if I did it, the tooth just didn't respond to treatment. So I love that. It's kind of funny. It's a great way to talk about it with Mrs. Jones. Mrs. Jones, we did everything we could, but your tooth just didn't respond. So it's not our fault. It's definitely her fault. So, but yeah, I always get a kick out of that. So our periapical and periodontal findings we'll definitely talk about. TMJ imaging, great area for that. We can see trauma really, really well. You can see your fracture lines very well. Pathological findings. Yes, you may not see pathology in your practice, but pathology will see you. And definitely want to make sure that we identify that. Airway and sleep apnea applications. Of course, we're not diagnosing obstructive sleep apnea with CBCT, but we are able to tell Mrs. Jones, you have a limited airway space, and let's go ahead and ask you some additional questions. Sometimes Mrs. Jones really doesn't want to put down that she snores. It's a little embarrassing. Cone-beam CT kind of opens up some of those conversations. Sinuses and nasal fossa, we see a ton of stuff within the sinuses. and the nasal fossa. Of course, orthodontic applications. There's, 3D printing applications, AI applications, segmentations, other 3D imaging as well. So there's a whole host of things that you can do with your CBCT. The two we're going to talk about today, just because of time, and that's quickly ticking away, is our implant imaging and our endodontic applications. So when we're looking at our CBCT, there's a general principle that 2D consistently underestimates the bone loss and it consistently overestimates the bone gain. And we do see that time and time again. So the number one reason for cone beam CT was our implant site assessment. And that's a great, really great reason for it. This was a position statement that came out from the American Academy of Oral and Maxillofacial Radiology in conjunction with dental implantology. And it specifically said that cross-sectional imaging should be used for the assessment of all dental implant sites, and that CBCT is the imaging method of choice for gaining this information. Now, this paper was in 2012, so that was a very long time ago. I believe in about 10 years ago, some of the malpractice insurances came and talked to us at our academy meeting. And at that time, they said that if an implant is placed and something goes wrong and there's no CBCT, the dentist is not defendable. They will just go ahead and pay that out. So that was about 10 years ago. So really, we've pretty well moved into this is fairly standard of care for our implant treatment planning. I think that, a good rule of thumb, if something were to go wrong, a CBCT is always obtained after the fact to see what's going on, and that's what's admitted into court. And so, especially from that standpoint, how simple would it be to take the CBCT ahead of time and make sure that we're not encroaching on any of our pertinent anatomy. I think that when we're talking about, a malpractice case, the thought process is always, I wish there was a CBCT ahead of time, and it would have, kept the dentist as well as the patient from having so much heartache. So I think that, especially when you have a CBCT, it's so easy to be able to, kind of plug and play with different implant types, with sizes. You can look at the optimal length and diameter. You can move it all around, axis of orientation, and that sort of thing. So from that standpoint, a CBCT is really helpful. The areas that we want to look at, of course, are our maxillary sinuses, our maxilla. We can look at the posterior superior alveolar neurovascular canals, the anterior superior neurovascular canals, the incisive canal, the ostium and the sinuses. So there's a lot of things that we'll mention when we are working up an implant case for some of our doctors. Of course, mandibular canal and mental foramen, our lingual cortical plates, we don't want to breach those. Remember our submandibular fossa, we have our lingual artery extending through that area. We can look, for example, at the bone quality, such as large marrow spaces. One of the best reasons for a CBCT system is a surgical guide. And this will give you, really a recipe, a cookie cutter recipe to follow. And so when I was going through my residency, I actually, as a general dentist, had been a little hesitant about placing implants. I didn't learn about it in dental school. And so I sat down with one of the prosthodontic residents. I said, hey, teach me how to do this. And so, of course, we sent out for a surgical guide. And it came back with, a level of guaranteed accuracy. It came back with, use this drill and this drill and this drill. And we were able to go ahead and place an implant. So if a radiologist can place an implant with a surgical guide, it is a very useful tool. We also did some of our research with some of our dental students, with third-year dental students. And we wanted to see the degree of accurate repeatability with using a surgical guide. And so you think about our third-year dental students, they're just getting up onto clinics. They're doing maybe the class 2s and class 3s. And we found that with a surgical guide, they were able to repeatedly, accurately place the implant within about 0.04 millimeters of the planned implant placement when they had a surgical guide, which is phenomenal. So we actually did another pilot study with a different implant system because we thought maybe that was just a really good implant system. And the degree of accurate repeatability with those third-year dental students for that one was 0.03 millimeters. So these are pretty accurate, and I think that's just just a great tool. I wish I'd had that actually when I was in general dentistry. It would have been quite helpful. So here's a case in which a surgical guide was used, very minimal space for this lateral, and you can see that the implant was able to be placed perfectly where it was planned. And of course, we know that just because there's a large area to place an implant and plan our implant, things don't always go the way we want. And so this is where this implant ended up, which is going to be a little bit more difficult as far as restorability. And we do see that quite a bit. So this one was an all-on 4, except for, whoops, that one didn't quite seat. This one could have benefited from some planning. The implant is in the sinus. Now, that by itself may not be an issue. We don't really have inflammation in the sinus or anything like that. But look at the degree of bone that is holding that implant in place. So that might affect the longevity of that implant. Sometimes we see, now I'm going to have to tell you my caveat. Radiology, we see the good, the bad, and the ugly. We have a very wide no judgment zone because we've been there. We know that things can happen. But sometimes we do see the people that have taken the weekend implant courses. And so, here we have an implant. I don't know how we're going to restore that one. So that could have maybe benefited from some implant treatment planning. This was another one. So we did manage to place the implant, but you can see this is really not restorable for this patient with that degree of periodontal bone loss. And sadly, the implant did encroach upon that mandibular canal, and the patient has neurosensory deficits. This was a case in which it was post-grafting. This is off the 2D, and they had placed, based off, I guess, off of the 2D, they thought that their post-grafting had integrated. And so they thought, well, our graft is integrated. It looks good. We're going to go ahead and place the CBC, or they were going to place the implant. But they did take a CBCT first. And we can see all is not quite well. It doesn't look the same as that 2D. We actually have a large fibrous defect. We have a lot of mucosal thickening that's actually iatrogenic in origin. And we're looking at it, where exactly did our, bone graft go? Well, the patient probably swallowed it. So it was actually a very expensive swallow. This is another one. This was post-graft. They thought, yeah, our graft has integrated. We have appropriate bone. And when they took the CBCT, this is what it looks like. You can see that graft obviously has extended beyond the membrane. We actually have a kind of an oral antral fistula. This is not integrated at all. This was another one in which this was post-site preservation bone grafting. Looks like it has integrated from the 2D. We get into the 3D. Again, we have large oral antral fistula. We actually have thickening and sclerosis of the cortical bone on that side. We have a chronic inflammatory process. We can see some remnants of that bone graft material as well. And actually, if we're looking at it, you can see some displacement of those cortical borders of the sinus. And this is called a mucocele. So if the sinus drainage pathway becomes blocked, the sinus can start to act like a pathological cavity and start to extend. And that, in fact, is what we see here. So now we have a chronic inflammatory process. We have a mucocele that is iatrogenic in origin, and this patient needs to go to ENT. Oh, this was another one. So they actually had already placed the implant. This was the previous graft. They thought everything looked great. And looking at it in the CBCT, you can see, no, the graft is actually to the buccal and not exactly where that implant was placed. So we do have a little bit of mucosal thickening here as well. This was another one. So this is based off of an angle posterior maxillary PA, which you know that's not exactly the amount of bone that patient has. This was actually a case by one of our specialists who's a fantastic specialist, placed thousands of implants throughout his lifetime, but all of us can have a bad day. And so, and just moving quickly, went ahead and measured, thought he had a particular amount of bone level. Actually came down to radiology, and the comment was that the implant was lost. And here we can see the implant floating with the carrier. And if you look carefully, the implant looks just as shocked as we do. So obviously, this is a really bad day. This is a bad day for the patient, but it's a really bad day for the dentist. And, this case could have benefited from a CBCT. This was another one. This implant has been placed based on the 2D. It looks great. It looks restorable. And yet when you get into the CBCT, where is it actually located? It's at the lingual aspect. And in our coronal sections, you can actually see this is the only amount of bone that's actually holding onto that implant. So that's actually not going to be something that we could reliably restore. This patient had a history of a failed implant. And it was new to this office. They went ahead and took the CBCT and they found the implant. So where is it actually? Well, it's actually osseointegrated. So about 90% or 95% of our implants are going to osseointegrate wherever they're at. So this is osseointegrated along the lateral cortical border of the nasal fossa, where it will live out its lifetime. This was a case in which they placed the implant, and we can see it's very, very close to that mandibular canal. We always want to trace the canal. If you look at the contralateral side, you can see we have some little bifurcations and trifurcations. Obviously, that's going to affect how they can place that implant, and we are just very lucky that this implant did not extend into that mandibular canal. We know our canals can bifurcate, they can trifurcate, they can do whatever they want. Here again, we have an implant within that mandibular canal in a patient that has neurosensory deficits. We can see superior accessory canals taking off. It's not uncommon. If you see it on one side, high likelihood you have it on the other. Of course, this is the third molar region, so you're probably not placing implants in that region. But if you are extracting third molars, you're going to want to know that. This is one in which we have a superior accessory canal taking off, and then another canal coming down and meeting that mandibular canal proper. Here we have complete bifurcated canals, or bifurcation of the canals bilaterally, and then we have anastomosis between those canals. And the same thing with our mental foramen. We can have one foramen, 2, 3. This patient has 3 mental foramens in the region of where we want to place an implant. So we probably want to know that that's there. All right, moving on to endodontic applications. This, was a root fracture case. This is one of my 2D versus 3D that I did for my research, my master's research. And you can see based on that 2D, yes, we still have an apical hypodensity. We have a large post, but that doesn't look to be involved. This looks fairly centered at our apex. And yet when we come into the CBCT and we're able to see between those cortical borders, we see a nice J-shaped hypodensity. It goes right to the termination of that post, lets us know that we do in fact have a root fracture. We may not always see the fracture line, especially if it's a root canal treated tooth, but we can see the evidence of that fracture. So if we have our non-healing root canal treated teeth, the things we're going to look for is, of course, an unfilled canal. And then we're going to look for any type of a bone loss or maybe a step defect along that root to let us know that we do have a root fracture. Now, we can see the fractures if they're displaced greater than the resolution of that machine. So if they are displaced more than the resolution of the machine, you can see that with our CBCTs. So, I can't say we don't always see it, but, we tend to want to look for additional evidence of a root fracture. So this patient came in, they had pain. They weren't entirely sure which tooth it was. Our posterior maxillary PAs have so much superimposition, and yet the CBCT shows, yes, we do have a nice apical radiolucency. So it identified exactly which tooth that was. And again, being able to see between those cortical borders is very helpful. Again, this is another case. They weren't entirely sure which tooth it was. Looking at the CBCT, we can easily see, yes, we do have a periapical lesion there. We have loss of that inferior cortical border of the sinus and a mucosal thickening that is odontogenic in origin. All right, so when we're looking at some of our research, we know that there is a correlation between our apical periodontitis and our cardiovascular disease. Anytime we have a chronic inflammatory process, we do have a correlation with cardiovascular disease. We saw that with our periodontal bone loss years ago. We also know, for example, the size of apical lesion at the time of root canal treatment does determine success. So if it's a very large lesion, when we try to treat that endodontically, we may not have a great success rate because there's just so much inflammation that's there. And so we have a greater risk of failure. And so in those cases, it may be better to go ahead and remove that tooth, let that heal, and place an implant. So we can easily see unfilled canals. We see those all the time, day in and day out. So definitely something that we are looking for. So here is an example case. This came over from one of our endodontists. The patient had continued pain and drainage. It looks like all of the roots were filled based off of our 2D. And yet when we look in 3D, we can see that the patient has an additional root. And so what they thought was the distal buccal is actually the distal palatal. And there's an unfilled distal buccal within an additional distal buccal, or I'd say an additional distal root. So that's our canal within our distal buccal there. And we can see it as you go through very nicely. So you can see all of your canals there, or all of your roots for this particular tooth. And then this was the post-op with all of the canals filled. And the patient had no more pain and drainage. Root fractures, again, we can see these root fractures very easily. Now, some of these are obviously huge, so everybody can see that. But you can see a nice, radiolucent line. This is a vertical root fracture in a tooth that has had root canal treatment. So while we do have a lot of beam hardening artifacts, and sometimes it can mimic a fracture, if what we're seeing does not line up with the endodontic feeling, then we know that we do have a vertical root fracture. This particular case, we have a root fracture as well as a large radicular cyst. And again, we can easily see it in our coronal sections. We can see a step defect here in our sagittal sections. All right, so this was a lesion that was between teeth number 8 and 9. They weren't entirely sure what it was. Maybe we have, an endodontic lesion. Maybe it's a nasopalatine duct cyst. And we're looking at the CBCT. It's very easy to be able to tell. So here's our canal right here, and you can see whatever this is not associated with that. So it's not a nasopalatine duct cyst. Could it be associated with this tooth? Maybe it could be. So there's our canal. Here's another one. We could see, we do have a large lesion, but note we do have the periodontal ligament space. Even our 2D, we can see that. But much better in the 3D. And you can see, again, it's not associated with the canal. It actually was not necessarily associated with the tooth. So we can see the tooth right here. It's not at the apex of that. And this was actually an odontogenic keratocyst. Here's another one. This tooth has been root canal treated, re-root canal treated. Now they want to go ahead and extract it and place an implant. And we have this large, well-defined scalloping apical radiolucency. We need to start thinking about other things, such as maybe an odontogenic keratocyst or a simple bone cyst, and it ended up being an odontogenic keratocyst. So if we have a lesion and it doesn't seem to be healing, we need to start thinking about some other things. This was a case in which endo was not sure whether they needed to treat tooth number 7 or number 8. This was the area they were looking at. This is a 60-year-old female. And in our CBCT, we can see, yeah, we have a large undiagnosed cleft palate. We have this large bony defect. That's what's being projected across in that 2D. So that's what they were seeing in the 2D. So they went ahead, sent it back, said, she has an undiagnosed cleft palate. She doesn't need to have endodontic treatment. And the endodontist actually called us back and he said, oh, I talked to Mrs. Jones and she doesn't have it. And I said, well, she doesn't have what? Well, she says she doesn't have a cleft palate. And this is the beauty of radiology. It's the facts, ma'am. So evidently, she would rather have had the root canal treatment than the stigma that goes behind being diagnosed with, say, a cleft palate. So I've never seen somebody actually want to have root canal treatment, but this lady certainly did. So, but again, the facts, ma'am. This one, a biopsy was recommended. They weren't sure exactly what was going on based on the 2D. Do we have a cyst? Maybe we have some sort of a radicular cyst. We've got a large restoration here. And again, we just have an anterior Staphny bone defect, which again, so you can see the symmetry. If you're not sure, you can always send that in. This was our anterior Staphny bone defect, and we don't really need to do anything about it. All right, this was a pediatric case, and we do have a hypoplastic tooth number 9, but they also had a lot of pain and drainage from the number 10 region. Couldn't figure out what was going on, moved to CBCT, and you can see we have a secondary root that was found, and again, was not noticed in that 2D. This patient had some pain and sensitivity on the canine, and actually we've got a nice lip piercing here, and that is causing some erosion of the buccal aspect of the alveolar bone as well as that canine. Kind of just a fun, interesting case. We can see root resorptions as well. We can see our external root resorption, say, versus a internal root resorption. Here's a case with our external root resorption. Obviously, this is going to be a very challenging case because we can see that incredible dilaceration. Back in our axial section, here's the end of the root. You can see that that tooth actually is, really nestled into tooth number 3 as well. So very challenging case. Our internal root resorptions, we can see this internal granular hypodensity letting us know we do have internal root resorption. This was another case. This patient had some pain and sensitivity, a little bit of widening of the periodontal ligament spaces. And you can see, yeah, we do have a fusiform enlargement of the canal. And you can catch this very early on so that we can fix that for that patient. Extruded endodontic material, we can see that. Now, that may not always cause an issue. In fact, many times it doesn't, but we can definitely see that. Any type of a foreign body, if a patient sticks anything in their body that calcifies or is hyperdense, we can see that. Here we have a retrograde endodontic filling. We have an apical hypodensity. See that right there. Majority of our endodontic treatments will have a small apical hypodensity. We call that a fibrous healing defect. It does not mean that it's non-healing. It could just be a fibrous healing defect. We have to go based off of the symptoms of that patient. So we don't want to just look at this and say, oh, they need to have root canal treatment. We need to take the patient's symptoms into account. So just know that majority of our root canal treated teeth will have a small little apical hypodensity, and that's just that fibrous healing defect. We can easily see perforations. So here we have a nice perforation. Here we have a nice perforation with associated bone loss. We have another, this is actually a perforation repair. And we see other things like our benign fiber osseous lesions. And remember, your benign fiber osseous lesions are more radiolucent in the immature stages, but these teeth should be vital. So we always want to do vitality testing. At this stage, this one's starting to become a little bit more mature, and we're starting to see that target shape appearance, that calcification, and within the central aspect of it. Again, really make sure you're always doing vitality testing on the teeth. Many times we see, multiple root canal treatments with these teeth. All right, this was one other case. This was a young female going through endodontic treatment. They wanted to look at the canine. Based off of our 2D imaging, everything else looks relatively fine. And yet when we get in, we can see there's extensive amount of bone loss around that first molar. A patient didn't even know she had it. She was not aware of it. You can see the degree of bone loss. This patient could have lost this tooth before she ever realized that she actually had an issue. Now, she does have a restoration on this tooth, and obviously that is the cause of our issue. But definitely something that we want to be able to identify, and the Cone CT is able to identify that much better than our 2D. So I think this is a great example of 2D is consistently underestimating the bone loss and overestimating the bone gain. All right, so here's some radiographic templates. You do want to go ahead and put something in your chart to say, hey, I did read this. And so this was, an example for an implant analysis. So, we could look at maybe, maxilla, mandible, airway, sinuses, TMJ. We're going to talk about what radiographic image was taken, the field of view, our contributing history, our reason for the scan, our justification for moving into that. This is another example. This is an example from my private practice of how we would talk about a scan. We'll have our patient information, our indication. If, happens to be one that's just taken for pathological overread, many times people will go ahead and take a CBCT when that patient comes in because they can get so much more information. But you also still need to have bite wings as well. We're not to all-in-one imaging yet. Field of view, and then we can go down through the different spaces: dentition, airway space, nasal cavity, paranasal sinuses, and our TMJs, and then other might be soft tissue calcifications, cervical spine, and that sort of thing. All right, a lot of information. Just a few more slides to talk about return on investment. So we're trying to get through it all. It was a huge Herculean task for today. Initial cost of the machine is varied. There are cheaper ones and there are more expensive ones. If it's really, really, really cheap, you want to be a little bit cautious of that. Just for example, like say if you're looking at eBay and somebody's selling, I don't know, like say pearls, and the pearls only cost $10, they're probably not real. A really, really cheap machine, you might be getting kind of what you pay for, and you may not have a lot of the bells and whistles or the algorithms that can say, reduce noise or imaging artifacts. So think about that. Probably don't want the cheapest one on the market. But, initial cost is varied. And what are some of our pros and cons with having a CBCT? Well, more accurate diagnosis and treatment planning in all areas of dentistry. It really becomes the foundation for digital dentistry. So you can use the DICOM files from your CBCT to do, pretty much anything that you want, all the way down to, if they say 3D printing and 3D segmentations, of course, your implant treatment planning, that sort of thing. And so there's a lot you can do with these. Patient education, it's great for patient education. They love to look at themselves. First of all, you just think about all the selfies that are out there, but imagine zooming through yourself. Very, very exciting and fun for patients. You can plan your implant. You can send them home with, say, the volume and the plan on a thumb drive. They can sit and look through it. They can share it with their neighbors, with their family members. We could see an increase in treatment acceptance with our CBCTs because the patient can see exactly what's going on. Liability coverage if something goes wrong. A lot of times people say, well, I don't want a CBCT because the liability of owning it. That's not what we're seeing reflective in the lawsuits that are occurring. We're actually seeing it's a greater liability if you don't have the CBCT and you're not taking the 3D imaging. And it's very similar to what we saw with medicine. So say, for example, if you have head trauma or anything like that, and you go into the hospital, they're going to take a head CT. It's just standard of care. If they didn't, they would be liable if you had a brain bleed or something like that. It's the same thing with dentistry. And really that gets pushed from the legal standpoint as far as, what's a standard of care. We do say it's what the people around you have. But at this point, a lot of people have a CBCT. So if you don't have one, definitely something you're going to want to look into. We see a lot of incidental findings, and that translates to more needed dentistry for the patient. And right there, you've got a nice return on investment as well. We're looking at the research of incidental findings. The research shows between 10 to 50% of findings that we do see are actionable. We do see at least 3 incidental findings per CBCT. That's very common, maybe 3 to 4. And our actions might be additional treatments, other diagnostic tests, active monitoring, or referring on to an additional specialist. Our cons, metal artifacts. So here we can definitely see we have some beam hardening artifacts around a metal restoration. Doesn't necessarily mean that that patient has cavities. So we do still need to take those intraoral bite wings. Please don't diagnose off all of your cavities off of a cone beam CT. There's going to be a high chance of false positives. So, we've not moved beyond the all-in-one imaging yet. CBCT and 4 bite wings. Yes, we see people taking that a lot. You do need to take the time to learn how to take a diagnostic image. You should probably take a 3D course, learn about anatomy and your interpretation. But anatomy and interpretation, it's just fun. So I don't see that as a downside, but I put that in there. Need to review the entire CBCT. It can take time. You can always partner with an oral maxillofacial radiologist. Dental insurance may or may not pay for the CBCT image, but you will diagnose a lot more needed dentistry. And actually, we are finding that the insurance companies, I believe starting in about 2023, did start paying for our CBCTs as long as it's justified. And then, of course, you can learn how to refer to medical insurance as well. We do see medical insurance used. You might have somebody in your office who is an expert in this, or you can bring in a company that can help you. And we do read for a lot of companies. We also find if there's a radiology report, they are more likely to pay for the CBCT. But here's Delta Dental. Cone beam CT coverage is here. This, I think, was 2023. These are some of our codes. I'm not going to read all of the codes here. If you want to take a quick picture of it or come back and look at this later, or you can even just Google it. So that's actually what I just did with putting some of the stuff together with all the codes, because I don't always remember all of the codes myself. Here's some medical insurance crossover codes. So yeah, you can, code out, the dental codes for panoramic, but you could also go ahead and code for medical. Again, here's another one for cone beam 3D multi-image reconstruction and the associated crossover codes for medicine. There's, of course, additional codes if you're talking about the temporomandibular joints. If you're talking about, say, atrophy, there's a lot of different codes. So you do want to do some homework in this area. You can call your insurance company as well and ask if they cover a cone beam CT. Sometimes there's paperwork, or sometimes you need to have some sort of an in-office pre-certification. So you want to make sure that you do that before you start trying to charge that out. So some of the insurance companies do require pre-certification beforehand. This is, what one of the insurance companies will use. This is the procedure, and this is why it's necessary. So this, gives you the justification for it, for getting that paid for. Reimbursement rates on average are between about $275 to $310 per CBCT scan. Tons of insurance codes. I left them all there for you. You guys can go back and see it. And again, you're never alone. You can always partner with the radiologist. This is my website as an example. This is a QR code to my website. It has a lot of different tabs. It tells you how it works. There's, different facts and resources. Here we have some CE courses. We literally take you step by step. Like step 1, you're going to do this. Step 2, you're going to do that. Step 3, you're going to do that. So we kind of walk you through it. And again, we do have resources. So if you need to export out, say, a DICOM file or anything like that from any different machine, we have it under our resources section. So you can figure out how to send a volume to a specialist. Because, of course, we want the actual DICOM files. We don't want the viewer. So that is a distinction, because we all have our own 3D imaging software. All right. And for some of the imaging companies, we actually have a plugin. So if you go to our website, you can install a plugin that will automatically go into your output section. It'll already say DRDX. You would just have to push that, and that would export out your volume automatically into our secure servers for us to review your scan. So again, remember, you're not alone. You know, there's oral maxillofacial radiologists like myself that are more than willing to help. So there is my email. We talked about the website a little bit. Again, if you ever need to contact me, please don't hesitate. I'm more than happy to help with any questions you might have. And with that, I know we went over. I apologize. It was a huge task today, but I wanted to make sure you guys had all of the information. Are there any questions?
Thank you so much, Dr. Kohlfarber. That was really fabulous and so much information. Thank you for taking the time to walk everyone through that. We do have one question that's come in, and this one is from Lisa Cox. More and more adults are doing ortho treatment. Would you suggest a scan before ortho treatment for adults?
I definitely would. A couple of reasons for that. Number one, I would want to evaluate the temporomandibular joints, because if the patient has a lot of osteoarthritic changes ahead of time, that may affect the bite for that patient. It's something that you would want to log ahead of time. You don't want that patient to come back later on and say, your orthodontic treatment caused this. So you'd want to go ahead and document it, let your patient know about it. Make sure that that is a patient that is a stable patient for you to work on as well. Another reason would be that you want to make sure that there's not a lot of apical root resorption. You would want to document that ahead of time as well, because again, that's something you don't want them coming back later on and saying, I didn't have any of this before you worked on me. You would want to know ahead of time. And if the patient has a lot of apical root resorption, you know, 1-to-1 root ratios, you really would probably want to mention that to the patient that maybe they're not a candidate for orthodontic treatment at this time. So yeah, there's many reasons I'd want to take a cone-beam CT on an adult that's going through ortho treatment. So great question.
Thank you, doctor. That is all the questions that we have right now. So unless there's anything else, I think we
Well,
can
here's
go
my
ahead.
information, and
Yeah,
if you guys have
great.
questions, please let me know. Thank you so much for spending your evening with me. I really appreciate it. Thank you again to Henry Schein for hosting this. I think it's so great to be able to share with everybody. And again, don't hesitate to contact me if you have any questions.